It's a pleasure to introduce the annual Arthur W. Ludwig Lectureship in Humanism and Medicine. This lectureship is part of the Advancing Idealism in Medicine initiative, which is a program that was founded by residents back in 2003 and includes monthly resident wellness and humanism curricula, research in resident well-being, grant opportunities and advocacy, and a Grand Rounds lecture series which seeks to bring inspirational role models in the practice of medicine, such as this morning's speaker, into this setting so that we can all learn from their example. The lectureship is named in honor of Dr. Arthur Ludwig. Dr. Ludwig came to Mount Sinai back in 1943, first as an intern, and after spending a number of years in the Navy, he came back to complete his residency in internal medicine, followed by fellowships in both pathology and endocrinology. He remained affiliated with Mount Sinai throughout his entire career. He served as an attending in the endocrinology clinic, as well as chief of the outpatient department diagnostic clinic. He was also a clinician investigator. He engaged in research activities while maintaining a busy practice. And he was regarded as a marvelous diagnostician and a strong advocate for patient care. He was a superb provider of compassionate care, and he earned the dedicated trust of his many patients. This morning's Ludwig Award speaker is Dr. Gurpreet, Dhaliwal, who joins us from the University of California in San Francisco, where he's a clinician educator and professor of medicine. He's also the Clerkship site director at the outpatient clinic, Clerkship site director for the medical students at the outpatient clinic at the San Francisco VA Medical Center, where he not only teaches students, but he also sees patients both in the inpatient and outpatient setting, as well as in the emergency room. Dr. Dhaliwal's educational and research interests are in the area of how doctors think, how they make diagnoses, how they reason, and what motivates them to make improvements in their own practice, as well as in the system within which they work. He is a member of the UCSF Academy of Medical Educators, as well as the UCSF Department of Medicine's Council of Master Clinicians. He has published widely, been the recipient of numerous awards, and has been invited professor at universities across the globe. We're delighted to welcome him today, and we have a plaque for him.
Well, thank you, Dr. Rip, for that introduction. Thank you, everyone, for the hospitality. This has been nothing but spectacular. The chance to meet with faculty in the Ludwig family last night and really learn about the legacy that we're here for today has been fantastic. Seeing the institution this morning, and then I have to confess, just a few minutes ago, perhaps my favorite part has already happened, which was meeting my former students and residents and all collecting for a quick selfie moments ago. But I think it is really a tremendous honor and also an important occasion to be here today, because what we do want to celebrate is sort of our central aspects of being a clinician. In learning about Dr. Ludwig's legacy, things I knew about him, of course, was his commitment to his patients, his commitment to the profession, but also his skill as a diagnostician. And that's the aspect of medicine that I want to focus on today, even though we honor the entire whole. When I started my training years ago, I had one question, which was of my mentors, which is simply this: like, how did you get so smart? You know, how did you become that good of a diagnostician? How are you that good at figuring out what's wrong with the patient and how we get them better? And I think it was a justified question when you were finishing training, because really that ability to reason is sort of a central tenet of what we do in internal medicine. It's a core part of our identity. It's something that people expect us to do perhaps better than any other specialty, which is reason. And if you really got down to it and you say, what's the procedure that we do in medicine? Our most important procedure is thinking. But when I asked around and I asked people, I say, how do you get that good? How do you get that smart? I got the same sort of stock advice I bet you guys have given and I've given myself, which is things like, well, just see more patients and read more. And even back then I had the sense, I was like, that's not it, because all doctors see a lot of patients, right? And all doctors read a lot. There has to be something else to becoming great at this craft besides just seeing and reading. And that disappointment about not knowing what does work was replaced by an enthusiasm when I learned that there's a science that studies what does work, and it's the study of expertise. And if you're interested in how people excel in other professions, it can be politics or business or music or sports, there is an entire field devoted to how people achieve excellence. And the whole reason that we want to study these people isn't to put them on a pedestal, but it is definitely to shine a light on them so we can understand what were the steps that they took in their path to greatness, and is there any small part of it that we can emulate it. But my enthusiasm when I learned when there was a field like this was replaced again by disappointment when I learned that medicine had never asked this question. Medicine actually has never studied what goes into making the mind of a master clinician. Now, to be sure, we have an amazing literature in medicine on what it is to be a fantastic clinician. And as we heard about Dr. Ludwig, that is an embodiment of what that is. We know what a great clinician is, and it rests on two pillars. One is the cognitive dimension, the ability to figure out what's wrong with this patient and have technical expertise in treating them. And then one is the human and interpersonal dimension, which is the ability to relate to them on a personal basis and really understand not just what's the matter with them, but to know what matters to them. And I would tell you that any of those mentors who I was asking about how do you get so smart, how do you get better, would endorse this, that being cognitively excellent isn't an optional part of being medicine. It's a moral requirement of being a doctor. But if you neglect the other part of the equation, that would be unacceptable. And really, although we're going to spend our time focusing on the former, I want everyone to understand that those two pillars of physicianship are intimately intertwined. And the only way you do a great service to yourself in a career as a doctor and to the patients that you take care of is striving for excellence in both. If you neglect that advice, though, and you just focus on being smart, you just try to get better and better and smarter, and try to figure out what's wrong with this patient to all ends, you might find yourself being on a path to look like this guy. And if you know the TV show House MD, then you'll recognize that Hugh Laurie, who played this character brilliantly, was totally a diagnostic genius, because every week he could diagnose the undiagnosable case. But I have to tell everyone when they say, is this what you're going to talk about? I say, absolutely not. Because he was brilliant, but he's the exact antithesis, right, of what we need in a modern doctor. He's smart, doesn't work very well with teams, though, right? He's not very good at high-value care. No one would say that he conserves resources. And I don't think he's the type of guy you'd say is bringing back the joy in medicine. So people ask me often, they'll say, well, then who's the role model for the modern day? And I'd say, it's actually not someone from right now, not this moment. It's someone who perhaps preceded him by a number of years. My real role models in diagnostic medicine, who I think we should aspire to, and honestly who I send my students and residents to who really want to get inspiration, are these guys. And you may not recognize them, but I'll introduce you to them. They actually, just like House, have a weekly show. Just like House, they're generalists. But then that's where the differences start to display. Because unlike House, they diagnose their patients just by history alone. They take multiple patients per hour instead of one. And then the best part about them is that these guys work in a team and they love their job. And if you need to know how, it's just how often they laugh. And if you don't recognize them from this photo reel, you may recognize them in their office. Because who I'm talking about are Tom and Ray, or Click and Clack, the Tappert brothers. And for over 40 years on National Public Radio show Car Talk, they have taken every and any manner of complaint that people call into their show to ask about. And when you listen to them, you can learn a lot about clinical reasoning. Now, people who know the show, can I get a show of hands who knows the show Car Talk? Fantastic. If you never caught it in its original iteration, and now one of the brothers has passed in the past year, it lives on weekly podcasts, which are just as good and timeless as they ever were. So I encourage anyone who wants to study diagnostic medicine to listen in. But if you listen to what they do, they tackle anything. They're just like a generalist. Anything that comes in the door is fair game. You know, people call in and say, well, my brakes are having this problem, and they'll give them advice on how to fix it. People call in and tell them about sounds, right? So people will say things like, well, my car kind of makes this like a thunk meow sound. And they'll say, well, you know, on that old car, I'd adjust the carburetor and I'd look for your cat because it might be in there. And they'll take anything. I mean, really, like, people even call in with metaphysical stuff. I've studied many of their questions that they get. One of my favorite was this. A woman called in years ago and she said, is it okay if I drive in the carpool lane if I'm alone in my car, but I'm pregnant. And they thought about that, and you'll see that in each and every answer that they get, they're incredibly smart. They know what the dx is, and they know what the rx is, and that part of them I really, really admire. But if you listen really closely, you'll see this too. You'll see that they know their stuff, but that they care more about the person than they do about the car. The science of expertise gives us insight not only in how you can be a house MD, but really how you can be like the guys on Car Talk or any physician role model that we aspire to. And it's captured in this graph, which really tells you anything and everything you need to know about the science of expert performance. This is a time performance graph, and it describes everything that every one of us has learned in our life, because every new skill that we picked up is governed by this S-shaped curve, which is that when you begin something, and this can be any skill, this can be in medicine I'll stick to now, this can be inserting a central line, interpreting CSF, running a family meeting, whatever it is that you're aspiring to get better at, or the entire profession of itself, is that everyone has slow goings. At the beginning there's just a slow ramp-up phase where you're trying to get the hang of things. In short order, you start getting on a really rapid part of the learning curve. In medical training, that would be the latter parts of medical school and residency and fellowship as you go on. And then eventually, you get to an inflection point. If you ask most doctors and survey them and say, when did you get comfortable dealing with the DX and RX of your specialty or profession, most people say it's about 5 years after the end of their terminal training, whatever that was, residency, chief residency, or fellowship. And everyone who's been there understands that that's a very comforting point when you can take care of 80 to 90% of what walks in the door every day. That feels great. But the key thing to know is that that moment of comfort comes with a price. Because as the number of, if you can take care of 80 to 90% of what walks in the door, that means there's only a few challenges per day. And as the number of challenges per day starts to decrease, then the amount of learning per day starts to decrease. And as the amount of learning per day starts to decrease in a cognitive profession like ours, that means that the rate of performance increase starts to decline over time. And when that happens day after day, week after week, month after month, and eventually year over year, what all of us are on the path to doing is becoming an experienced professional. And an experienced professional is marvelous. There is no moral judgment around this. An experienced professional does great service to their families, to their patients, to their families, to the people that they work with, and the people that they train. It's a fantastic course to take. The only person that you may do a disservice to is yourself. Because by settling on being just an experienced professional, you're declining or depriving yourself of the chance to become an expert. And an expert here isn't meant to be a competitive term. It's not one doctor versus another. It's just one of our own selves against another opportunity. And a key point here that's worth emphasizing is on this graph, which is that just because you do something for a long period of time doesn't make you great at it. It's so important for everything we do that's worth emphasizing. Just because you do something for a long period of time doesn't make you great at it. As an example, I've been writing ever since I was in grade school, right? But it's not like I'm getting showered with book contracts. I've been driving ever since I was in high school, but it's not like NASCAR is knocking down my door and saying, come drive with us, right? I have 2 boys, they're 8 and 10, and I love those 2 guys to death. But it's not like either one of those 2 thankless kids has ever nominated me for Parent of the Year. And honestly, after 11 years, I feel like I deserve it. And that's because in every one of those things, writing, driving, parenting, and probably most of the medical skills that I aspire to, I do what every single human being does, which is that I improve until I'm good enough, and then I divert my mental energy elsewhere. When you see people who pursue excellence in a given field, what you'll find is that as they get that good, they take their liberated mental energy and they reinvest it back into their own development. This has been studied in a number of fields, but it hasn't been studied in ours. So what we're going to be doing here today is adapting what other fields have learned and trying to apply it to our world as clinical reasoners. But the key lesson from all of them is this. Whether it's been studied in firefighters, chess players, or ICU nurses, the same punchline comes up over and over and over again, which is people who achieve cognitive excellence in their profession figure out a way to learn more on the job than the rest of us. They get more out of their workday than the rest of us. And how they do that is just by dialing up two variables. They either increase the quality, meaning what they get out of every case they see, gout, monocular blindness, jaundice, or they increase the quantity, the number of times that their brain sees that challenging situation. They dial up one variable or the other. Some people do it just by luck and happenstance. It's the nature of their work. But what you see when they study experts is that most of the time it's by design. And the way that they operate is that they understand that learning is a lot like immunization. That you have to be exposed to something the first time. That's critically important. The first CHF, the first multiple myeloma, the first choledocholithiasis. That moment is critical. And you want to imprint on your brain when you can. But then they understand this, that to really get great memory cells, it's not just about the inoculation. It's about the booster shots. And they do anything and everything in their power to increase the quality and quantity of booster shots that they get. So what we're going to do here is review 4 lessons that come from other professions and see how they can, and I can tell you have been, applied to our world of clinical reasoning in medicine. The first is the concept of progressive problem solving. The long name is progressive problem solving and reinvestment. And it was discovered by 2 researchers now over 2 decades ago named Bereiter and Scardamelia. And they weren't studying doctors, they were studying teachers. So they learned that there's teachers that are on the path to becoming experienced teachers, and there's teachers who are on the path to becoming expert teachers. And what they discovered is that all teachers, just like anyone who enters a profession, essentially has a to-do list. Like when we enter medicine, we have a to-do list. It's like all these things you have to learn, like note to self, learn CHF, note to self, learn how to interpret arthrocentesis fluid. It's the same deal in teaching. And what they observed, of course, is that all teachers, when they entered the profession, did the things on the to-do list. Learn how to create a lesson plan. Learn how to discipline a child, and learn how to interact with a parent and communicate with them. And in short order, all teachers on the rapid part of the learning curve started learning how to do those things. And they did what all humans do, is that they take joy in sort of checking things off your to-do list. Everyone loves that feeling. And of course, every teacher did that. And what they discovered is that the experienced teachers got to that point very quickly, checked off the things on their to-do list, and then sort of started to become more comfortable in the job. When they observed the teachers who were destined to become experts, they saw something different. They also enjoyed the ability to check something off their to-do list, but that satisfaction was just momentary. And then they put something right back at the top of their list. So they said, like, I know how to discipline a child. Now I need to learn how to discipline a child with special needs. I know how to create a lesson plan now. I need to create a lesson plan that a substitute teacher could use right away if they walked in the classroom. I know how to communicate with parents. Now I need to get better at communicating with parents who have English as a second language. And of course, if you think about it, every teacher would be inclined to learn those things if they had to. If the moment asked that of them, almost every teacher would do that. The difference in the teachers who were destined to be expert teachers was that they learned it in advance, so that their brain had already been there when it showed up in real life. It's not hard to imagine how you can adapt this to our life in the clinic or in the ER or in the hospital wards when we're very busy, because all of us are. And you say, who wants to make their life harder? Well, it turns out that some people do, but they have a way that does it that fits into their workflow. It's sort of small microfeedings. Take, for instance, if we're in the emergency room or we're in clinic, and someone comes in with right lower extremity erythema, and you look at it and you say, well, you know, I have to rule out DVT, I think it's cellulitis, I'm going to prescribe a familiar antibiotic, and I'm going to educate my patient and send them on their way. That's marvelous. That's what an experienced doctor would do, and that's great service. An expert doctor would do something different. They would see the red leg, consider DVT if it's a possibility, prescribe a familiar antibiotic for suspected cellulitis, educate the patient, and send them on their way. But then they do one small micro challenge that the moment doesn't require. They do something like they'd say, like, well, I already know you have to rule out DVT, and I've thought about gout, but do I really have 2 more things on my differential diagnosis if this person comes back and it's still a red leg? They might say, like, you know, I didn't prescribe antibiotics for MRSA, and I know I'm going to see the ID fellow at noon conference. I'm just going to ask her if she agrees that that was logical not to cover it in this case. Our clinic today is super busy. It's crazy busy today. If I had my med student with me today, how would I possibly teach him in the 2 minutes that we're walking from this patient to that patient? What are the 2 pearls I would say? Do I have them on the ready? And make no mistake, every doctor would look up stuff when they have to, right? Everyone does that. That's part of our moral compass. That's what we do. The difference is challenging yourself to make those small moments of learning when you don't have to, in preparation for the inevitable moment with those 3 examples when you're going to need to. And everyone has their own way to do it. I tend to check things on my phone. I tend to cultivate my network of colleagues who I can ask quickly for the learning. But I do anything and everything in my power to get just a little bit more out of the case. And do I do it for every case? Absolutely not. But I do my very best just to move the needle a little bit so that when you're going through a routine case in the or a routine day in the clinical environment you're in, you get just a little more out of it than you could have or you might have expected to. And this is something that actually has been studied in medicine. So a number of years ago, Joan Sargent studied the highest performing physicians, family medicine physicians in Nova Scotia. And these were the top docs by 360-degree assessment, which means that they were the smartest and they were the kindest. They were the best docs in the community. And they were as busy, if not busier, than everyone else. But what they found was that every time they were taking care of patients, they had a 2-track mind. They needed to figure out, what can I do for the patient in front of me? And then what can I learn for all the other patients who are going to come later? And it just reminds you that no matter how busy we are, you're not in control of what walks in the clinic or what walks in the emergency room or what gets admitted in a call night. There's no chance of that. You're not in control of that. But you are in control of what you get out of it. Okay, second method. So if you look at diagnosis and therapeutics, what those really are predictions. We're really in the prediction business. We operate under an imperfect data set, and we do our very best to put a label on someone and then prescribe a treatment course. And so prediction is something that can be measured and studied. And it turns out there's actually a large academic research body on what professions are excellent in prediction. And there's a couple that stand at the top of the heap. There's 2 in particular that are exceptionally good in prediction. Does anyone know what they are? It's not medicine, otherwise we wouldn't be here.
Meteorology.
Meteorology, so one is meteorology. People don't expect it, it's true. Meteorologists are amazing in their predictive capacity. All the jokes that the weatherman suffers are totally not justified. That is not evidence-based joking at all. You should know the meteorologist. Now, I'll come back to the second in a little bit. Let me continue with the meteorologist, because that's an excellent guess, and that was right on. If you think about the work task of a meteorologist or the weather person, and you thought through what they do at the simplest level in the pre-computer era, this is what it was. It was taking a collection of data, doing our best analysis, making a prediction, and then looking out the window to see if you're right or wrong, and then you come back the next day to try again. Think about that workflow for a second. Take data, make a prediction, see if you're right or wrong, and come back the next day and try again. Let me step away from the professions and ask people this. What percentage of Americans do you think believe they're an above average driver? Anyone know? Like, what people think, hey, I'm above average, I'm a cut above.
90.
Yeah, these numbers are exactly right. It is the 80 to 90%. It's statistically impossible, but 80 to 90% of Americans think that they're an above average driver. And you have to ask yourself, like, what is the psychological situation that leads to that? I mean, humans have some tendency towards overconfidence, and that's probably adaptive, and it's important. But why is it that we really think we're that great at driving? It just can't be. It turns out if you look at driving, it has these characteristics. You drive every day, you drive to and from work, to and from school, or to and from the store, and you don't have a major incident, a near miss, a ticket, an accident. You start to create a story in your mind that says, hey, you know, I'm a pretty good driver. And day after day, that is what gets you to start creating your estimation to the 80 and 90%. Day after day, you create that story. Very often, people, as they're creating that story of, hey, I'm a great driver, they also have this other parallel story, which is everyone else on the road is an idiot. And that's not true, but that's what the mind goes in those 2 splayed directions. But if you put this in people's car, and you give them a little more data on their driving, their speed data, their acceleration data, images of when they turn and accelerate, what people find is that they're not as good as they think at driving. You know that the yellow light I thought I was running was actually a red. when I cut into a lane and I thought, well, that went really well, it turns out that the camera takes a snapshot of the person behind me, and the hand gesture, which I'll only incompletely replicate here, tells me maybe I cut it shorter than I thought. And when I was talking on my cell phone and I took a left turn and that seemed totally routine, it was pretty routine to me, but it wasn't to the little girl on a bike that I nearly missed hitting. And when people get that kind of data on their driving, what happens is two things. One is that they lower their estimation of their driving to the more realistic 50 to 60% range. And the second is that they're motivated to get better. The world that we live in as clinicians is actually a lot more like driving than it is like meteorology. Clinical reasoning captures one aspect of being a doctor, which is that we have an incredibly incredibly high decision density. And that means the number of decisions that we make per unit time are unrivaled. If you look at places like the primary care setting or the emergency room or any other busy clinical setting, the number of decisions per unit time is unrivaled. But the amount of feedback that we get on all of those decisions is quite scant. And that has a very pernicious effect. You know, I'm a full-time clinician, so I have a great job. I love it. I'm an internist, but I spend half of my time in the emergency room and I spend half of my time in the inpatient setting. And it's an awesome job. It's kind of an odd one because I do them both at the same time, so often I'm admitting patients to myself. But what I get to see in that arc is how things go from start to finish. But that even with my job, that's just a rare, rare gift. More likely in a busy day in urgent care, I don't find out what happens to the majority of my patients. So I might see a young man who has a fever and a sore throat and cervical lymphadenopathy, and I'll say to him, well, it looks like you have a viral URI and this should pass with time. And if I check the EMR or call his PMD or just run into him at my hospital a few weeks later and see that he's doing well, what my brain will say, well, all things being equal, the next time you see this problem, the same situation, proceed in the same way, and that would be really logical. If I see that young man who has a fever and sore throat and cervical lymphadenopathy, and I say, well, seems like you have a sore throat, and I send him on his way, and then I learn 3 weeks later that that was his index presentation of non-Hodgkin's lymphoma. And I learned the same way. I called his PMD, or I called him, or I checked the EMR. I have the chance to look back at my own performance and say, hey, could I have done better? Like, why did I only examine the neck and not any other lymph node beds? Was I really justified in thinking sort of an unintentional 5-pound weight loss in a healthy guy made any sense at all? And I have the chance to go back, and the next time my brain sees that problem, I can try to do better. But for the vast majority of patients that I see, and I bet many of the ones that you see as well, we don't find out what happens. And there's all sorts of structural reasons for it, right? People go from inpatient to outpatient, doctors rotate on and off services, EMRs and health systems don't talk to each other. The reasons are legion, but the fact is clear. We oftentimes don't know what happened to our patient. And what do you think the human brain does with the outcomes of all of the patients that it never hears about? The human brain makes a decision and it doesn't know what happens. Where do you think it files it? Yes. The human brain operates under a no news is good news paradigm. And that may be self-serving, but it isn't if you're trying to become better in our craft. So I may go home and think I'm a great urgent care doctor because of that guy I took care of 3 weeks ago with a sore throat, even though he's sitting across the street in the hospital getting chemotherapy dripped into his veins. And the only remedy to doing this, to really getting better at our craft, is getting feedback on our decisions. And what I have to tell you is the best systems that I have seen have not come so much from the students I've worked with, and they haven't come so much from the faculty that I've worked with. They've really come from the residents when they enter the field and say, I want to get better at this. And the things that I've seen have evolved over time. It started with sort of very orderly systems of triggering note cards that say, I'll check them in 6 months and see how the patient did, or 6 weeks. Then it evolved to sort of black books and Excel spreadsheets. Now it's migrated to EMRs with automated reminders and people keeping incredible tracking systems on their tablets and phones. And it's not that we don't have any feedback in medicine, we just don't have enough, right? I definitely will hear from a colleague or two say, hey, your patient is back, or sometimes I get a chart I have to sign in the EMR and it reminds me to check on how a patient's doing. Sometimes, I stumble into M&M and there's my patient being presented. Like, there's feedback in medicine, it exists. But it happens in a random and sort of haphazard way. And if we're really trying to get better at it, we have to shift from something that's sort of haphazard to something that's more systematic. And in the end, I'm going to ask you to reflect on how you might do this. But I want you to know this. There's a couple tips I can share. One is you can't do this with every patient. I have tried it, and it is overwhelming. Even if you had a half-time practice, it's overwhelming to do this. So you have to commit yourself to random sampling. And the second is to think about what cases you want to track. Because all of us, just in our wiring of internists, are always going to track the interesting cases. Like, was that a pheochromocytoma or was that mastocytosis that accounted for the flushing? I just got to know. And definitely track those ones. Those are interesting and they keep us going. But if you really thought about the ones that you need to track, they're the common things that you're going to see again and again. Like, was that gastroenteritis or was that appendicitis? Was that a heart attack? Or was that a heartburn? And you really have to track those. And I have to tell you, when you do it, I can say it's laborious, sometimes it's humbling, but most importantly, it's essential. Because it is one of the hardest forms of CME that you'll do, but it's also the very best one that you'll ever come across. Okay, on to the third method. The first two methods that I mentioned on that graph, which is quality and quantity, dial up the quality. They're the same patients. You're seeing the same patients as anyone else or you would have been doing before, but you leave a stronger imprint on your brain, either by learning a little bit on the margin while you're on the go or tracking the patient to find out what really happened to them so you can close the loop in your own mind. But if you look at other professions who train people to make high-level decisions, they don't just increase the quality of the experience, they do increase the quantity, right? Business schools do case studies, the military does war games, and pilots sit in flight simulators, all to put their mind through the paces of the high-level decision-making and reasoning that they have to do. And we certainly have this opportunity as well. We have dozens, if not hundreds of cases that we could go through that come through our inbox and our mailbox every week, if we so desire, to learn in a way that those other professions do. But there's insights that have to be gleaned before we do it. It just can't be casual reading. And one of the biggest insights actually comes from the world of chess masters, which is another field where expert cognition has been studied. The chess has sometimes been called the Drosophila of expertise research. And for the docs in the room, you'll know that Drosophila, probably hundreds of thousands, if not million, were sacrificed so that we could all learn genetics and understand how genes mingle. Well, the same is true of chess masters. Probably scores and scores have been studied and scrutinized and subjected to experiments so that we can understand what goes into the expert mind. And in looking at top performing chess masters, the grand masters, what the researchers have found is that they read a lot. Now, I would say no one thinks it's a big news flash or a spoiler alert to say that you'll find a chess grandmaster in the library instead of a bar on a Friday night. That's not the point of the research. The point of the research isn't that they read, it's what they read and how they read. When they study the reading habits of chess grandmasters, what they find is they spend an inordinate amount of time reading chess cases. They read previously published chess games so that they can recreate the mental trace of those games in their mind and burn them into their own neural networks. They're not reading chess research. They're not reading chess review articles. They're not reading evidence-based chess. They're putting their brain through the paces of the case so that they can remember it when it's game time. And if you think about many of the cases that we get, you can do the same thing, but it takes a very special form of reading. This is a case that comes from a few years ago from the New England Journal of Medicine. And in it, you might look at it and say, well, this sounds like the typical challenging case that I'm used to seeing. But if you did skip ahead, you would see that it has a very unexpected and tragic ending. That it's a 25-year-old who starts with a cardiac arrest. It ends in brain death, and then there's an intestinal schistosomiasis that's called to account for it. If you looked at this, you might say, this is so rare, this is so unexpected. There's just nothing that replicates the world that I practice in that I think I'm going to take a pass on this week's case. And that first glance reaction might make sense, but it's not justified because there's gold in this case. You just have to find it and read it in a way that replicates what that pilot was doing in the flight simulator. So one of the things you have to do when you read a case is you have to hide yourself from the title. No one walks into clinic saying, hi, I'm a 47-year-old man with epistaxis and granulomas. So you cannot look at a title if you're really trying to challenge your brain. You have to cover that. The second thing you must do is you have to hide who's presenting the case. I know this sounds odd, but I can tell you when I find out that an endocrinologist is presenting a case of abdominal pain, I get really good at diagnosing adrenal insufficiency. Even though in real life I miss that diagnosis far more times than I care to admit. And then finally, you have to get to the business of solving the case. And if you looked at a case like this, you might say, well, what is there? Well, this is what you do to replicate what the pilot does in the simulator, which is he doesn't just focus on the takeoff and he doesn't just focus on the landing. It's all the curveballs that his instructor throws at him on that entire journey. So if you look at a case like this, you might say, well, here's a 25-year-old man who has cardiac arrest, and then you stop. And you quickly say, like, do I know the reasons a 25-year-old would suffer this? Is it drugs? Is there an unexpected cardiomyopathy? I learned that he's in VFib, and I quickly stop. Just a quick quiz, and I say, do I remember, is vasopressin in or out? Or is it back in? I can't remember. And you quiz yourself in that moment just to be sure. You see that he's hypotensive, and you try to anticipate. This is just mental retrieval. What organs might be affected because I know that he's hypotensive. And then finally, you stumble upon the fact that he's in South America, and that triggers a neural network, and you say, Chagas disease, I remember it. And then you might say, that's all I remember is Chagas disease. But even if you remember that it exists, that moment is a small neural victory, because what you do is you go to Wikipedia, and I'm saying it right here, you just go to Wikipedia and just remind myself, oh yeah, it's this parasite that affects those two major organs, and you move on. And the point about this is that you can get so much out of the case, not for how it started and not how it's finished, but everything in between. If you take your attention away from the solution, which is so clean in a case like this, and try to replicate the struggle, which is what the clinicians who were taking the care of this patient really faced. People who want to do this now don't have to do this by pen and paper. I still do so only by habit. But now you can do it online, because the New England Journal of Medicine and all the other journals that post their cases oftentimes do it in an interactive way where you learn exactly in that manner. It's case, question, quiz, learning, repeat. And that goes on, and you go through the case in a way that makes you live it just like the treating clinicians did. You're in the flight simulator. And people who are teachers in this room should know that you can bring this to your classroom as well. Some of the students in this room have been on my ward team, and they know this is what we do, or the ex-students and that we do this, that we take to the board, and we take a case like that, and we break it down. And I put everyone's name on the board from top to bottom, and then I put the case as it unfolds from left to right. And we relive the case as a team. And of course, we talk about pericarditis, and could this be pulmonary embolism? But we also talk about the clinical reasoning. You know, are we worried about pulmonary embolism because it's a real consideration here, or because we're just influenced because we talked about that in morning report today? And what they see is that we give as much airtime to the medical facts as we do to the reasoning behind grappling with them. And I always tell people who ask about reading strategies, I really make a pitch for reading cases. And people who are steeped in the medical, or the academic and publishing world will know that in that world, cases have a very low impact factor. But I can tell you in the cognitive world, they have the highest impact factor possible. You just have to read them in the right way. The last method is perhaps the most celebrated method for how you become an expert in something, and that's called deliberate practice. And that's something that we can adapt in anything and everything that we're trying to get better at. It's a method that's promoted and really discovered by K. Anders Ericsson, but now has been widely acknowledged in many fields, and certainly in medicine. And it's simply this: if I want to get better at something, I don't hope, and I don't hope that the passage of time does it. Instead, I recognize where I am, where I want to be, and then I try to do a series of feedback loops that close the gap between the two. Now, you don't need any theory and expertise research to know this, because everyone in this room has lived it. If you had a music teacher or you had a coach when you were growing up, then you've lived deliberate practice, because it went like this. You said, hey, teacher, I want to play the whole piece. And he says, no. You have to play this stanza right and get it right over and over and over again, and then you can play the whole piece. Hey, coach, we want to scrimmage. We want to scrimmage and kick around. Coach says, no. She says, you have to sit here and kick 20 penalty kicks, and unless you can get 19 out of 20 in the upper right-hand corner, there will be no scrimmage. Everyone understands the difference between drilling and scrimmaging, and that's the difference between deliberate practice and not deliberate practice. I heard about this a long time ago and I loved it. I thought it was an amazing concept. But I have to confess, I was trying to find examples of where it is in our daily life. And I didn't see it until a mentor of mine told me a story of his. My mentor is a master clinician, and I admire his cognitive firepower like no one else's. But he told me about a story when he was a student on the East Coast, and as a fourth-year student, he went to a prestigious school in order to learn physical exam. He was very interested. This was 40, 50 years ago, and he said, I need to go and learn physical exam. And so he went to this hotshot place, and he did what you're supposed to do. He followed a professor around every day on rounds, and he looked at a rash here, and he looked at a spleen there, and he listened to a heart or two. But his real goal was to get better at the cardiac physical exam. That was the embodiment of an internist. It was the coin of the realm. And for better or worse, he's like, that's what I want to get better at. And he recognized that just following a professor around on rounds every day and listening to a heart or two wasn't going to get him where he needed to be. He and his patients deserved better. So he figured out something. He said, well, he had a lot of free time after those rounds, so every day he'd go to the pre-op board and see all the patients who were on for valve surgery the next day. And in that era, there was plenty of rheumatic fever and there was plenty of valvular disease. And what he would do, he would go to the patient's bedside every evening, just briefly hear their story, listen to their heart, and then in 2 days' time, find out what the pathology was for those valves. He only did it for a month, but he made a quantum leap in his auscultation skills, which to this day are unparalleled. You know, hoping that following a professor around with a heart exam 2 a day will make you great at auscultation, you can call that practice. But finding every patient in the hospital who has a valvulopathy and listening to their heart and then finding out what it was is deliberate practice. And you have to ask yourself, what do we do in medicine as practice versus the other? Now, I have to say, I wouldn't expect any of us. It is not realistic for any person in this room to do what was done back then. But there's no reason that you can't replicate that in some small way. Like if you're really interested in getting better at your cardiac exam skills, and every one of us could get better at it, can you start to create a habit where you listen to someone's heart, keep a record on a spreadsheet or a book or your phone, and then find out what the echo showed a couple days later, and then go back and listen one more time? Complete that loop. All of us would, I bet you everyone in this room would say, like, I could be a little better in dermatology, right? I could stand to learn a little more about rashes. But instead of wishing that I was better at rashes, can I have a rash sent to my inbox every morning? And it's a quiz that I have to take, and you can sign up for the service. And I can't turn it off until I can get 80% of the rashes right. Otherwise, that thing is coming in every morning. And some of the rashes aren't that pretty. That's deliberate practice. So you have to ask yourself that there's many, many things we want to get better at, but just ask you this. We're always fond of saying, I'm in the practice of medicine. But instead focus on one skill and say, what am I in the deliberate practice of? This is a summary of the methods that we've talked about in this session, which are really a compilation of things that are derived from other fields where the question has been asked, not how do you become experienced in a realm, but how do you become expert? Not how do you become good at something, but how do you become great at it? And in a moment, I'm going to ask you to turn to your neighbor and discuss them, but I want to give a brief overview. The on-the-job learning, every one of us learns when we're on the job. It's part of our moral fiber. That's what we'll do if a patient is sitting in front of us. But if we need to get better, do we learn only when we have to, or do we learn in advance of that moment? Every one of us loves feedback on our patients, but we just don't get enough. Do we continue to get feedback in a random and haphazard way, or do we create a system to track our patients? If you'll take my advice that says reading is the best form of interaction with the medical, reading cases is the best form of medical interaction with the medical literature around, can you commit to that? And then can we change it from a spectator sport where we casually read the article or the case into a simulation exercise like that pilot in the flight simulator? And then finally, with all the skills that we all need to get better at, can we switch from saying, I hope I get better over time, to having this urgency to say, I need to get better at something over a fixed period of time and do it with deliberate practice? For the next 2 minutes, what I want you to do is just turn to your neighbor, look at this graph here, and understand that this is not a prescription. This is just a menu of options. In the world that you work in the clinic or the environment where you work, some of these may be more realistic than others. But are there any of them that you're doing really well that you can share with the person next to you? Or are there any of them that sound really good to you and you can share with the person next to you that you're going to commit to doing? Spend 2 minutes, turn with your neighbor, and then we'll come back for some concluding comments. 2 minutes with your neighbor. back together. Sorry, I don't know how to, let's come back together. I don't want to curtail discussion. Someone know how to whistle? I can't. All right. I hate to curtail discussion because I think this is the reason we come here, isn't to hear one person talk, it's to talk with your colleagues. But I will tell you this, what I'm asking here is hard work. This is not easy, make no mistake about it. And you may wonder, like, why do people do this? Why do you commit to improving your own performance when it's outwardly acceptable to everyone else around you? That's what this is asking. Why do you commit to improving your performance when everyone else around you finds it perfectly acceptable? And it's a really great question, and I will tell you, I'm not here to tell you that it's easy. In every profession where expertise has been studied, it takes an extra amount of work. No question about it. It'd be an incredible amount of hubris to feel like that wasn't the case for medicine. So I'm not here to tell you that it's easy. I'm just here to tell you that it's worth it. And if you thought about many of the great clinicians that many of us are trying to aspire to emulate, Dr. Ludwig or many of the other great ones around us, I'm sure they would endorse that notion. But sometimes I tell people it's hard work, and they say, well, listen, these are difficult times for doctors. There's no reason to do this. They say, no one thanks you for this. No one pays you for this. There's no blue ribbon when you try to do this. And I say, those are all fair statements. They're true. And I was in a room where I was getting some responses like that, and I said, I didn't have rejoinders for those. But then someone stood up in the back of the room. She raised her hand, and she's a young doctor who was just finishing her training. And while everyone else is saying, you shouldn't do this, she was the only person who stood up and said, you should. And I said, why is that? She said, well, if there's any chance I could be a better doctor tomorrow than the one I am today, then I owe it to all my patients to do that. And I concluded my remarks, and I took a seat because I said to myself, I just couldn't have said it any better. Thank you very much for your time and your attention.
We have time for questions. Please. Thanks very much.
Thank you.
I'm from Brooklyn. I know you're now from the West Coast, but we had a writer you probably know of, but before your day, for which you won a Pulitzer Prize, I think, writing a great book about a softball player in Brooklyn, who was an Orthodox Jew. So he wore a skull cap, and he had sideburns, and he had all the garb and all the practice. But he was the best softball player in the whole area of Brooklyn. And Bernard Malamud, the writer, called the book The Natural, and you're a natural.
Thank you, that's very kind of you. I appreciate that. Thank you.
I'm really impressed watching all the decades pass about the percentage of foreign-born physicians who practice in America. It's a great mixture, but it's a worry to me, and perhaps to you too, because of the cultural gap, not the educational gap, the cultural gap, especially about age. Most of the people who come from the Far East or wherever they're coming from are used to patients who are 10 years old, feverish, diarrhea, and when they come to America, they find everybody is 80 years old, feverish and diarrhea. So I wonder if you've thought about or instituted anything to bridge that gap.
Yeah, I think a lot has been said about the contributions that come from foreign-trained doctors when they come to the U.S. And I think some of the points I can expand on, if not endorse, that certainly there's a cultural divide that needs to be bridged. Some places, I will say, residencies do a marvelous job of actually acculturating foreign doctors to some of the U.S. practices, et cetera. My father, he trained in England, and he reminded me after he moved from India to England, where he was doing his MRCP training, how he needed the sister at the time, who was the head of the hospital ward, to translate, because he would say things like abdomen to the patient, and she would translate it to stomach or tummy or something along those lines. And he appreciated so much how someone served as his translator of language and culture until he was able to acculturate himself. I will say that foreign trained doctors, many of them who are amazing clinicians because they grew up and trained in an environment that doesn't have the technology and other things we have, but are forced to use observation and direct hands-on skills, come here and then struggle in a world where we sort of emphasize all the technology instead of the bedside stuff that now we're working very hard almost to retrospectively bring our doctors around. So I think there's things to learn from both worlds.
Fantastic talk.
Good to see you, Rajesh.
Really some amazing lessons. Question for you is, where in sort of medical education or career trajectory should these skills be taught?
Good point. Early on, and I know that's the easy answer for everything, but I do think it has to be early on because if you can do these early on, then they start to become habits. As soon as we start to get out into practice and develop our own routines, then they start to feel like add-ons, right? They start to feel like add-ons, and that's a very difficult place to insert a new learning behavior. So for instance, if you took the issue of feedback, one of my colleagues at UCSF, Surisha Narayan, she is really trying to build feedback into our R1's experience where they track patients after they leave the wards and then come back a couple months later and say, how did my patient do? And make that a structured thing. Because if they get the habit, and I think for lack of a better word, if they get hooked on that, finding out how did my patient do, then it'll start to become part of their practice. If we introduce it to someone after they've been out in practice and they have the routine, it's a little harder to add on. So I think don't have to do all of these things, but they have to be sort of bled in slowly over training.
This is a great talk.
Thank
Thank you so much. Just a question. I'm curious in the master clinicians that you studied, if you got a sense of what their job satisfaction is. And the reason I ask is because I would imagine that those people who become experienced physicians at 5 years start to divert that mental energy perhaps to other things like trying to become the father of the year or something like that. And so for those that might want to be that best doctor they can be tomorrow, I wonder if they sort of feel compelled to do that. And in so doing, maybe they have no time left for the rest of their life, and how does that weigh?
Yeah, great question. And it dovetails a little bit what we talked about yesterday. We were studying Dr. Ludwig and how he was so good at what he did, and it turned out that he's also a Renaissance man. And it led to a conversation of, are you informed by not wholly dedicating yourself to medicine, but just dedicating yourself to excellence and seeing if that informs your medical mind when you're there. I do think when you study expert clinicians, you'll find that there's something that they are spending more time on that we're not seeing. It is something like a tracking system that they're doing, or that they were early on in their career. We may not see it now, but there was a period of time when they took on a much higher burden of patients, or moonlit, or did something else that increased their mental exposure. I don't know how often the effort is sustained for the 30 or 40 years, because by the time we see someone as great, that job that they have today may not reflect what the early investments were early on. But I don't think any of them, and I know in fact when you study, there's some extra effort that's hidden in there. You just have to uncover what it was, because it's not always evident now.
Right here, question.
So, first of all, thank you, as everybody else says,
Thank you, my pleasure.
On Dr. Gompertz's curve there, where you become good and then it's close to a plateau, but gradual increase, there you're learning facts.
Yeah.
And you have to keep on learning facts in medicine because new ones are being found all the time. But to be great, you need judgment.
That's right.
And that's what the higher curve is really showing. You're developing judgment how to use the facts. It's not just a question of getting more and more facts, but also using them in a better fashion.
I would endorse that wholeheartedly. I think sometimes what people say is you need to keep up with the literature. But I think in reality, people use these phrases like in 10 years, 50% of knowledge is replaced. I don't think that's true at all. CHF today looks a lot like it did when I first saw it. Sure, some of the meds are changed, and now we know how to ultrasound some things here or there, but the core tenets of it are in place, and I've replaced a few pieces of old knowledge with new knowledge. But the judgment that's informed by the amount of times I was right or wrong about diuresing someone and how I did handle or didn't handle the renal failure well, those were all moments of judgment, not new facts that I learned. And uploading by tracking through feedback or asking someone to come to the bedside and help correct my misperception around things had nothing to do with the textbooks or journals and everything to do with trying to make a better judgment the next time my brain saw this problem. So I would endorse that completely. You have to keep repleting the facts on the margin, but it's really that refinement of judgment, how you grapple with the facts, that makes this curve inflect the way it does.
So on behalf of the department, I want to thank Mr. Ludwig and her family for continuing to support the department and having this lectureship. So I very appreciate that. Thank you, Dr. Dhaliwal, for this wonderful talk.
Thank you so much. Thank you.